So let's continue, right? The muscarinic receptor antagonist.
So, anyway, na certificate nankasa, but opportunity anyway na certificate.
Foster, please mute your microphone.
Okay.
So with the muscarinic receptor antagonist, you remember I said acetylcholine can go and bind to the M3 receptor. Yes, there are drugs which can be designed or which are available to block those receptors. So before proton pump inhibitors and A2 receptor blockers were developed, okay, before they were developed, these two were developed. Atropine and niscongenes were used in peptic ulcer treatment. And what did they do? They go there and block the muscarinic receptor, blocking the acetylcholine from binding to the muscarinic receptor. Administering high atropine dose reduces gastric acid secretion because the acetylcholine can no longer go and bind to that muscarinic receptor. Okay. However, the side effects that comes with the atropine doses, no, okay, causes blood vision, urinary retention, and other side effects. So that was why they started looking for other drugs, such as proton pump inhibitors and what? A2 receptor blockers, like cimetidine, ranitidine, famotidine. All right. So we move on. Now, unlike atropine, we have paresipine, okay, which is a selective M1 receptor antagonist. And this paresipine reduces gastric acid secretion by antagonizing, blocking acetylcholine, okay, which will go and bind to that M1 receptor. That paresipine goes there and block, okay, that way from acetylcholine binding to the M1 on the enterochromaffin-like cell. Okay, so here in this case, there's no production of histamine there to go and, stimulate acid production. So it is fairly effective when used as a peptic ulcer drug. So that's for paresipine. Now let's talk about the cytoprotective agents. Okay, so these agents are designed to protect the tissues that line the stomach and small intestine. So here, what they do is that they provide a physical barrier over the surface of the ulcer. So for the acid to even touch the cell, they use their self, or they act as a physical barrier, okay, to to protect the tissues of the stomach. So here we have drugs like sucralfate, bismuth chelate, and misoprostol, which is a prostaglandin U2. I said this one normally deals with the production of mucus, that misoprostol. But with the sucralfate and bismuth chelate, they go in there, attach themselves to the walls or lining the tissue lining the stomach, and then they act as a physical barrier against the acid that is being secreted. So the sucralfate is a viscous polymer of sucrose, octasulfate, and aluminum hydroxide. Now, this sulfated polysaccharide adheres to ulcer craters. You know how acid works. As soon as it falls inside on your skin, it starts creating dents. Okay. So this drug goes there and bind to the ulcer craters and epithelial cells. And in that case, inhibits pepsin catalyzed hydrolysis of mucosal protein. Hmm? So here it inhibits pepsin, I told you, produces acid. And when acid binds or gets into contact with the mucosal proteins, it breaks it down, it destroys its structure, and therefore now the acid will now get a direct contact with the stomach lining tissues. Okay. So what the sucralfate does is that it goes and fill those gaps, the craters, caused by ulcer, and then prevent that pepsin catalyzed hydrolysis of the mucosa protein. Now, sucralfate, what it does is that it also stimulates prostaglandin synthesis in mucosal cells. It also stimulates mucus and carbonic secretions. Now, this action contributes to the formation of a protective barrier to acid and pepsin, and also facilitates the healing of ulcers. The pharmacokinetics of the sucralfate. It is administered orally as a tablet or suspension. Please, I hope you know what tablet is and what suspension is. Please, pharmacology 1, try and know the difference between tablet, pill, suspension, and whatever. The drug here is not well absorbed from the gut. That's why it's able to line and fill the craters, the ulcer craters. They are primarily excreted in the feces. Some of the clinical uses here, it can be used to treat active ulcers or to suppress the recurrence of ulcers. It is less effective than H2 receptor antagonists and proton pump inhibitors. But I said proton pump inhibitors is long acting, compared to H2, which is also a kakra, like can also last for some hours, but it's not as compared to the proton pump inhibitors. Oh, okay. I thought someone was marking the screen, not knowing it was myself. I'm sorry. So here it is mostly used if patients cannot tolerate the above two. So here, when someone can tolerate the H2 receptor antagonists or proton pump inhibitors, maybe the person is having some effects afterwards. Normally, we give the sucralfate, and this sucralfate goes there and rather fill in the ulcer spaces and protects the stomach lining and helps with the production of the mucus. There have been occasionally reports of constipation and other GI disturbances. The drug may impair the absorption of other drugs such as digoxin. And digoxin is a drug used in the treatment of heart failure. So if it impairs the absorption of digoxin, that means that the person will die because heart failure, the person can't even pump blood throughout the whole body. And this drug is impairing it. Be disastrous. Also, it can also impair ketoconazole and phenytoin. Now, to prevent this, sucralfate should be administered about 2 hours before other drugs. Now, the side effect here is that it can cause dry mouth, nausea, vomiting, rashes. Okay. Now we are done with the sucralfate. Now let's look at the bismuth chelate or the bismuth subsalicylate. It is believed to have mucosal protecting action. It coats the ulcer base and absorbs pepsin. So for it, it absorbs the pepsin. Doesn't block, it absorbs. It also enhances local prostaglandin synthesis and stimulates carbonic secretions. It is used in combination regularly for the eradication of Helicobacter pylori. Now, the drug bismuth chelate has toxic effect on the bacillus. It prevents bacteria's ability to adhere to mucosal surface. Bismuth chelate also inhibits proteolytic enzymes of Helicobacter pylori. The pharmacokinetics is it's poorly absorbed. The little absorbed is excreted in urine. If renal excretion is impaired, if you have challenge with your kidney, please, it means that it's going to be disastrous because there will be high plasma concentration of the drug, which could cause encephalopathy. The adverse effects here includes nausea and vomiting, and they are more common with the bismuth chelate. There is also blackening of the tongue. So if you take bismuth chelate and later you find your tongue being black, please don't blame your gods in the village. It's due to the drug. When you take the drug, it can blacken your tongue and sometimes your stool. Now we move on to the misoprostol. Misoprostol, like I said, is a prostaglandin analog. And when you use acid NSAID too much, it can cause peptic ulcer because you block the cos1 and cos2 enzyme. Therefore, you can't produce prostaglandin E1 analog, which can produce mucus. So when you use too much of NSAID, as you block this enzyme, you can't produce that prostaglandin. You have low levels of that in your system. So to do that, to balance that effect, you have to supplement your system with misoprostol. And misoprostol is a prostaglandin E1 analog. Okay. Misoprostol reduces acid secretion via the CMP-dependent pathway by binding to the prostaglandin receptor EP3 on parietal cells. And I was saying that the receptor EP3, anytime you see CMP, it means that it's a gene protein coupled receptor. Now, what does it do? It exerts cytoprotective effect by promoting the secretion of mucus and carbonic from superficial epithelial cells. Now, it is used as prophylaxis against peptic ulcer in patients taking NSAIDs on long-term basis. The adverse effects includes diarrhea and abdominal cramps. Okay, and here misoprostol can also stimulate uterine contraction and induce labor in pregnant women. So here it is contraindicated during pregnancy. Okay, you don't take it when you are pregnant, unless maybe, of course, you have an agenda to remove some living organism in your stomach. Anyway, drugs from the Helicobacter pylori can also be eradicated. Okay, so the discovery that Helicobacter pylori plays a role in peptic ulcer has led to so many methods to remove or kill or eradicate the bacteria. So we have the single drug therapy, which is mostly rarely effective in the eradication process. Hence, normally we use multiple drug therapy. So the most regimen include a proton pump inhibitor or H2 receptor antagonist. Then you follow it with two or more of the following, which is amoxicillin, clarithromycin, bismuth chelate, metronidazole, or tetracycline. These are all antibiotics, okay? So you can give a proton pump inhibitor, which is longer acting compared to the H2 receptor antagonist. And then you add two or more antibiotics in addition. Now, studies show that a three-drug regimen of a proton pump inhibitor and two antimicrobial agents can give 90% eradication of the Helicobacter pylori species. So usually it is omeprazole, amoxicillin, and metronidazole, this combination. Or sometimes it is omeprazole, clarithromycin, and amoxicillin. The regimens with clarithromycin may provide higher eradication rates in a short period of time. That means between 7 to 10 days, you should eradicate everything when you use clarithromycin instead of what? Amoxicillin, instead of metronidazole. Mm. Now we move on to laxatives. I quite remember during my SHS time, I used to take laxative so that with the idea that it will push out things, unwanted things. Yes, Chancellor raised the hand. Chancellor, you can write down your questions so that I'll read and then. Hello? Yes, I'm listening. Or you let me continue after the class, then we'll talk about it because it's being recorded. Now, laxatives are drugs that stimulate intestinal peristalsis. They also increase the movement of material through the bowel and facilitate defecation. So it means that once you eat or you take in something, it decreases the time that substance that you've eaten will spend in your stomach. It just decreases the time and then facilitates the push out of that substance you've taken in. So it facilitates defecation. Laxatives are mostly used to treat constipation. Mm. So you remember I said one of the antacids can lead to constipation. Aluminum hydroxide can cause constipation. Okay, and the magnesium hydroxide has a laxative effect. So mostly we combine the two to offset each other's differences. Here, laxative is different. Okay, for it, they are mostly used to treat constipation because of its ability to stimulate intestinal peristalsis. So they are used to evacuate the bowel prior to surgery or diagnostic examination. So before surgery, the doctor has to clear all nasty things from your intestine, and it it they would administer laxative so that they don't want to see anything then strange. Okay, otherwise they can even collapse. Just joking. And they are also used to eliminate drugs or poison from the gut in case of overdose or poisoning. Remember, when you take in drugs, okay, the drug has to be absorbed. So here, when you use laxative, it will even push the drug away through the small intestines quickly into the large intestine. You excrete it even before absorption, because when absorption occurs and these poisons get into your systemic circulation, that is the end. You can die. Mm. But giving a laxative can quickly push the drug out of your body. Okay. Now, people often, especially fat people or people who want to reduce their weight, believe that when they take laxative, they are going to lose weight because they become less heavy. Please note that you are only losing water when you take a laxative, okay, not the fat, okay, because laxative, the pathway it's using is through the stomach and not into systemic circulation. And when that happens, it leads to a lot of trouble. Okay, you'll be walking by the street, and before you realize, something falls from you. Anyway, just by the way. So here, people who use laxative as a means of losing weight are losing fluid, not fat. Okay. So know that if you are fat and you think, oh, you are taking it to reduce your fat, please be careful. Otherwise, you'll be walking, like I said, and something dangerous can come out from your anyway. So laxatives are classified according to their mechanism of action. So depending on how they act, they are called names. Okay. So we have bulk-forming laxative. We have surfactant laxative. We have osmotic laxative. We have stimulant. Okay. But see, if you're able to pick the exact cause of the happen, do you still have to do the triple therapy? No, please. The triple therapy is for Helicobacter cause, okay? But in Ghana, I've never seen a day where they can pinpoint or diagnose that this is where the thing is coming from. Maybe it is due to acetylcholine problem or Ghana, we've not gotten there. You get it? But it will be advisable to go with the triple therapy because many or most of our food that we eat, most of the food that we take in are sometimes contaminated. Many a times we eat from the roadside. And I know many Ghanaians who bear with me that most roadside food tastes better than even the restaurants. Okay. So it's likely that we will be infected one way or the other.
The ones closer
I've
to the
never
gut.
seen I've never seen wachi tasting better than wachi sold by the gutter.
The biggest gutter.
Anyway,
The
yeah.
bigger the gutter, the sweeter the water. That's it.
Okay. So let's move back to the laxative. Okay. So depending on the mechanism of action, it is giving names. So we have bulk farming, we've got surfactants, we've got osmotic, we've got stimulant, we've got lubricants, and we've got saline. Now, of the various types, only bulk farming can be used on a long-term basis without noticeable side effects. So long-term use of the others, which includes osmotic and stimulants, may lead to electrolyte depletion. Okay, you know osmosis, movement of ions and whatever. So as these ions are getting out of your system, you are depleting your electrolytes. Mhm. And also the use of osmotic and stimulant laxative over a period of time could lead to dependence. That means after a while, then you end up developing uh, 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 an interest in taking the drug always. So let's go into details by taking each title one by one based on their mechanism of action. With the bulk forming laxative, they are undigestible hydrophilic substances that resemble natural dietary fiber. These agents are polysaccharide polymers that are not broken down by processes of digestion in the upper part of the GIT. So here they act by retaining water in the gut lumen. So when they are not digestible, but when you take it, it gets into your stomach and it absorbs water, okay, in the gut lumen, okay? And this retention of water promotes the peristalsis, okay? And they take several days to work, but it has no serious side adverse effects. So you can bear with me if you know Max International, they employ that same mechanism with meta switch. If those who have joined Max International before, you know about the product called Meta Switch. And this Meta Switch, because they did it to help fat people reduce their weight, just because as this Meta Switch absorbs water in your stomach, it makes your stomach full and you feel like, oh, you are not hungry and therefore you are okay. Okay, and but in that case, you have just absorbed this polysaccharide, which doesn't give you energy, it's not digestible or anything. So indirectly, it is making you think as if you've eaten, but you've not eaten. That's what the meta switch does. So it's the same system in our bulk forming laxative. It absorbs water, but here, as the water piles up in the system, it leads to what? It promotes peristalsis, and the effect takes days to, like, for it to work, it takes days to work, but have no serious adverse effects. So some of these include pectins, methyl cellulose, and certain plant gums such as sterculia and bran. Please, anytime you see bold words, it means that pay attention to that. You may see it in your exams. Now let's move on to the stimulant laxative. The stimulant laxative include a large group of natural and synthetic compounds And here they act on sensory nerve endings in the gut to stimulate peristalsis directly. They irritate the intestinal mucosa, which results in excess gut motility. Okay. So we have some drugs, okay, belonging to the anthraquinone derivative. Anthraquinones is mostly found in, it's a compound found in aloe vera. Okay, aloe vera. And here they also increase water and electrolyte secretion by the mucosa. So maybe if you are there and you think you are taking aloe vera juice, please be careful. Before you realize it has this laxative property due to anthraquinone present in them. And you'll be walking by the streets, and before you realize you have sold certain things in your trousers. Mm. So examples include castor oil, cascara sagrada, and we have plant extracts of senna, please, senna. Hmm. And we have synthetic compounds like the diphenyl methane derivative, bisacodyl. So we have anthraquinone derivative, which include castor oil, cascara sagrada, senna, and we have the synthetic compound, which is the diphenyl methane derivative, which is bisacodyl or bisacodyl. Some of these agents are frequently used and abused in the treatment of constipation. So bisacodyl is usually given by suppository, causing stimulation of the rectal mucosa. Please note that anytime we give drugs via suppository or the rectal route, it gives 50% bioavailability and 50% metabolic activity. I hope you've done bioavailability. You do it in pharmacology 1. So when you get there, you understand. So bioavailability, just by the way, is the fraction of drug that enters into systemic circulation in its unchanged form. So here, bisacodyl, no, okay, it's given via the rectal route by suppository, okay? And this results in increased peristaltic action and defecation in 15 to 30 minutes. Now, senna has laxative activity because it contains derivatives of anthracene, okay, example, imodine, and this is combined with sugars to form glycosides. Now, the drug passes unchanged into the colon where the glycosidic bond is hydrolyzed by bacteria. This releases free anthracene derivatives, and the derivatives have direct stimulant effects on the myenteric plexus, resulting in increased smooth muscle activity, leading to defecation. So this is the mechanism of action. The derivatives have direct stimulant effect on the myenteric plexus. You see it in your exams by all means, resulting in increased smooth muscle activity, therefore leading to defecation. Now let's move on to the surfactant laxative. These agents are also called fecal softeners. So for them, they normally act on the surface tension, surfactants. So always remember, they change the surface tension of fluids in the bowel, causing an emulsifying effect in bowel contents. This makes them retain more water and hence it softens the stool and makes it easier to pass out. On a whole, they have a detergent-like action, just like the way soap can be used to, you know, um, wash our oily bowls. That's how it acts. So please, have 9 minutes more remaining. After this 9 minutes, we'll continue tomorrow. I hope it's fine.
Yes,
Yes,
Doc.
sir.
So this surfactant laxative, and they also have a weak stimulant activity. So we have example including docusate sodium, we have glycerin, and we have liquid paraffin. few adverse effects, but occasionally cause mild GIT reactions. Now we move on to another laxative, which is osmotic laxative. You know, osmotic, they normally deal with ions. So here, the osmotic laxative consists of poorly absorbed solutes. These maintain an increased volume of fluid in the lumen of bowel by osmosis. This accelerates the transfer of the gut contents through the small intestines. This results in an abnormally large volume of gut material entering the colon. And when that happens, there is purgation about an hour later. And the main salts in use here are magnesium sulfate and magnesium hydroxide. These are virtually insoluble and remain in the lumen and retain more water. Remember, wherever salt goes, water follows. So these two, okay, causes retention of water in the lumen. Now with the osmotic laxative, the amount of magnesium absorbed after oral dose is usually too small to cause serious adverse effects. They should be avoided in children and patients with poor renal function. If used in these groups, effects like heart block, neuromuscular blockage, or CNS depression could occur. Now we have lactulose as an example of osmotic laxative. It is a semi-synthetic disaccharide of fructose and galactose. In the colon, the bacteria converts its two component sugar, which are poorly absorbed, and the component sugars are fructose and galactose. When these are fermented in colon, the lactic and acetic acids function as osmotic agents. They usually take about 2 to 3 days to act. Now here, the unwanted effects, especially with high doses, include flatulence, cramps, diarrhea, and electrolyte disturbance. Now we move on to the saline laxative. So we have examples being magnesium hydroxide, magnesium sulfate, sodium phosphate, and citrate. The mechanism of action. They increase osmotic pressure in the bowel, which aids in water retention in the gastrointestinal tract. The magnesium salts may also stimulate the secretion of cholecystokinin, which increases intestinal secretion and motility. So please note the mechanism of action. The magnesium salts may also stimulate the secretion of cholecystokinin. Kinin is always movement. So, and cysto or cyto mostly involves cells, okay? So movement in the cell, okay? So which increases intestinal secretion and motility. Now with the side effects of saline laxative, it can cause hypotension, hypermagnesemia, abdominal cramps, diarrhea, gas formation, and also respiratory depression. So we move on to the anti-diarrhea agents. Can we stop here so that we continue later tomorrow?
Yes, doc.
Yes, doc.
Yes,
Yeah.
doc.
So let's end here. Tomorrow we continue with the rest and then we end. Please, do you have any question?
Please, doc. Doc, please, the bisacodyl that you said, is it only in suppository? Because I've seen some in tablets.
Come again, I can't hear you.
The bisacodyl,
Yes.
please, you said it's in the form of suppositories, but I've seen some in tablets. What about that one?
But here I'm talking in terms of its activity for laxative.
Oh, okay.
Yeah. So what happens is that it just acts just like our local enema.
Okay.
You know how our local enema
Yes,
works,
please.
right?
Yes.
Normally, our mothers grind some herbs and they'll pour it inside the enema and they'll push through your rectum. And surprisingly, they have a surprising way of doing it. They just raise up your leg, shake you, and before you realize, it will act as a laxative at the end of the day. So what happens is that there is an irritation of the rectum, and that causes the laxative effects.
Okay.
You get it? Yeah.
All right. Thank you.
Welcome. Please, are there any more questions? Because I'm actually tired and I want to sleep. Are there any questions in the chat? All right. So then next week we'll look at the anti-diarrhea effects. Okay. Anti-diarrhea. I said next week. No,
tomorrow or next
sorry.
week?
Yes.
Tomorrow.
Yes.
I'm tired. When I'm tired, I commit mistakes. I'm tired. So I work at Legon too. So my day has been hectic. But please, so far so good. Do you enjoy the lecture?
We are actually enjoying it. But
Are there
please,
any
when are we
comments?
having? My concern is when are we getting the slides, please?
Oh, you get it today. The
But the previous
hypertension,
one,
I've not given it out.
yes, please.
Because you've not asked me. You get it? So you should ask me. The reason is I do forget. I'm not handling only you. You get it?
Okay.
I'm working at Legon. I'm working with an organization, Target Malaria, and it's at UK. You get it? So I'm handling a lot. So if you don't remind me, I'll forget. Do you get it? And for me, I thought I've done online. You have a recording of my section. But if you still want the slides it will be available to you, okay, for your perusal.
All right,
so in case you have any challenge, my telephone number too is there, okay, so that you can quickly reach me. You can even ask your class rep, give you my number, and then we will talk more about your questions. I hope it's clear.
Yes, Doc.
So hopefully, I'm hoping to complete all our lectures in March. I hope that's fine.
Yes, Doc.
Doc, then about the examination method too, then
it will be of G's.
Clue about how
it will be of G's.
Oh, okay.
Okay. Wasn't it of G's for the previous studies, previous exams?
It was.
Yeah, so it will be of G's. Okay. The only thing I advise is to read the instructions carefully. Okay. Because you have maybe possible answers which you have to write either true or false for each possible answers given. Okay. So I will be able to know your performance, okay, at the end of the day. Maybe 100 questions, give you 2 hours or 30 minutes to see how you guys. And I'll try and make sure that level 400 will write together the 300s, okay, so that I can get your grades ready in April. I hope it's fine.
Yes, that's fine.
Very well.
When you get your grades, I'm sure you'll be happy. And even if it doesn't reflect and you call me, you want to know your grade, I'll tell you your grade. I hope it's clear.